You can take your seat, SH. Okay, all right, thank you. Good morning, honorable members, and good morning, our stakeholder. Welcome to today's engagement. Today we are engaging the Ministry of Health alongside the central hospitals and other selected health facilities that are before us. But before we go into the details of the discussions, may I ask honorable members to introduce themselves for our stakeholder to know who is who in this parliament. Starting from that corner, please.
Thank you very much, Chair. Through you and all the stakeholders around, good morning. My name is Fales Deborah Mpohamoyo, representing the people of Chitipa North constituency. Thank you.
Through you, Chair. Good morning, everyone. My name is Aidan Jenga, representing the people of Doha West. Thank you.
Through you, Chair and all stakeholders, thank you. I am Mwisho Alexander Chirikuntima, representing the people of Ncheu Central East, specifically from Senior Chief Makwangwala, Senior Chief Gwanya, and Sabutien Kutomola. Thank you.
Good morning, Chair and everyone. I'm Hastings Kajomba, Choro, Kwanjini Mangunda constituency. Thank you.
Good morning. Through Chair, Right Whale Alex Mahoe is my name, representing people of Mzimba Solola, and I'm a member of this committee. Thank you.
Good morning, Chair. I'm Jeremiah Jumbe, representing the people of Blantyre Southeast constituency.
Thank you, Chair. My name is Veronica Ndalama. I am the MP for Blantyre City South Lunzu constituency. Thank you.
Good morning all. Through you, Chair, my name is Urunji Fikanyirenda, representing the people of Mzimba Perekes constituency. Thank you.
Chair, morning. My name is Mackenzie Nkwazi Chipalamoto, representing the people of Nkatabe North constituency, and I'm a member of this committee. Thank you.
Chair, good morning. I'm Ruben Ikanyama, MP for Mangojo West.
Good morning, Chair. My name is Arthur Sungitsa, representing Doamputu.
Good morning, Honorable Chairperson. My name is Chance Mudali. I come from Chitipa South.
Good morning. My name is Maureen Chifundo Seorachirwa. I represent the people of Mwanza West constituency, and I'm the vice chairperson of this committee. Thank you.
Through you, Honorable Chairperson, I am Sunge Kalumo, Parliament Secretariat.
Through you, Chairperson, I'm Enres Nyale, Parliament Secretariat.
Through you, Honorable Chairperson, I'm Judith Malua, Parliament Secretariat.
Thank you very much, and my name is Anthony Masamba, Chairperson, Parliamentary Committee on Health. At this point, may I humbly our stakeholder to introduce themselves Those who are seated behind, could you please come in front and speak on the microphone so that the camera person should be able to capture you and should also be able to be audible. And just to inform you that we are live on Parliament TV and our Parliament Facebook page. Thank you very much.
Thank you very much, Honorable Chairperson and the committee. My name is Dr. Dan Namarika. I'm Secretary for Health. With us, we have members from 3 central hospitals, Mzuzu Central Hospital, Queen Elizabeth Central Hospital, and Kamuzu Central Hospital. We also have districts from Cholo, Chirazulu, and Likoma. We are pleased, Honorable Chair, that we have district commissioners from those councils, and I think that is much appreciated. Mulanje excused themselves, and I hope your office received this apology. So they will be introducing themselves. Thank you, Chair.
Thank you.
Thank you, Chair and Honorable Members of Parliament. My name is Amos Msekandiana. I'm the Director General for Kamuzu Central Hospital. Thank you.
Good morning, Chair. I'm Dr. Doris Kayambo, Director General, Mzuzu Central Hospital.
Good morning, Chair. I'm Patrick Kamalo, Director General for Queen Elizabeth Central Hospital.
Good morning, honorable members. Through you, Chair. I'm Chikonti Margareta. I'm the Chief Internal Auditor in the Ministry of Health and Sanitation. Thank you.
Good morning, Honorable Chairperson and members of the committee. I'm Mrs. Celestina Mame, District Commissioner for Chirazulu District Council.
Good morning, Chair. My name is Nelson Kamwana. I'm the Director of Health and Sanitation Services, Chirazulu District Council.
Through the Chair, I'm Miriam Jerry Nyasulu, Director of Health Services, Cholo District Council.
Good morning, Chair and the Honorable Committee. I am Abubakar Nkoma, District Commissioner, Likoma District Council. Thank you.
Honorable Chairperson and honorable members, my name is Dr. Grayson Matewe, Director of Health and Sanitation Services for Likoma District Council. Thank you.
Good morning, all. I'm Chisomo Petijere, Chief Nursing Midwifery Officer under Likoma Council.
Good morning, Chair, and good morning, committee members. I'm Noro Dagamau, District Commissioner for Cholo District Council.
Through the Chair, my name is Talumba Mankogwe. I'm a physiotherapy specialist from Queens.
Good morning, Chair and all honorable members of Parliament. I'm Collins Perry from Kam Central Hospital.
Good morning, Chair and all honorable members. I am Catherine Emi Iliaya, Deputy Director, Human Resource Management and Development, Kamuzu Central Hospital. Thank you, Chair.
Honorable Chair, point of order.
Point of order, sustained. Yes, what is out of order? Can you hold on? Can you hold on, please? What is out of order?
I submit to you, Chair, that when they are mentioning their names, they can raise up their voice because we can't hear their names.
Thank you very much. Point of order sustained. Would you please speak up when you are introducing yourself, please? And be closer to the mic. Thank you.
Through the Chair, I'm Francis Mpinganjira, Ombudsman Officer at Cholo District Hospital.
Good morning.
Through you, Chair, I am Felix Monia, Principal Health Service Administrator, Chirazlo Decho.
Good morning, through Chair. I'm McJoy Barker, Principal Human Resource Management Officer, Chirazlo Decho. Thanks.
Good morning, through you, the Chair. I'm Montford Nkoma, Health Service Administrator, Choro District Health Office. Thank you.
Good morning, Chair, and all protocols observed. I am Yohane Biles, Controller of Administration, Kamuzu Central Hospital. Thank you.
Good morning, through you, Chair, and the whole House. I'm Joseph Kondwe, Chief Accountant, Mzuzu Central Hospital. Thank you.
Good morning, Chair. I'm Sipo Nyasuru, Hospital Administrator, Queens.
Good morning. I am Dr. William Peno, Deputy Director, Queen Elizabeth Central Hospital.
Good morning, Chair. I'm Dr. Wiseman Piri, Deputy Director, Mzuzu Central Hospital.
Good morning, Chair and honorable members. I'm Timothy Soko, Hospital Administrator, Mzuzu.
Good morning, Chair. My name is Maureen Banda. I'm Human Resource Management Officer, Mzuzu Central Hospital.
Good morning, Chair. I'm Zuze Kawale, Deputy Director, Nursing Services at Queen Elizabeth Central Hospital. Thank you.
Good morning, Chair. My name is Matas Bondwe, Chief Nursing Officer from Mzuzu Central Hospital.
Good morning, Chair. I'm Chigonde Naison from Cholo District Hospital, the District Nursing and Midwifery Officer. Thank you.
Good morning, Chair. I'm Matthias Londo, District Medical Officer, Dikoma.
Good morning, Chair. I'm Dr. Dennis Solomon, District Medical Officer, Cholo District Council.
Good morning, Chair and all members. I'm Linda Mauluka, Controller of Human Resource, Queen Elizabeth Central Hospital.
Good morning, Chair and all honorables. I'm Patricia Kapena, Chief Nursing and Midwifery Officer, Chirazlo District Council.
Good morning, Chair and all honorable members. My name is Veronica Nkugumira, Chief Preventive Health Officer, Chirazlo District Council.
Good morning, Chair and all members. I'm Austin Gachingwe, District Hospital of Chirazlo pharmacist.
Good morning, Chair and all honorable members. I'm Dr. Charles Murego, District Medical Officer, Chirazlo District Council.
Thank you very much, our stakeholder, for those introductions. Like I already indicated earlier on, we are engaging you today, specifically on the state of corruption in health facilities. This inquiry is becoming following the investigation that was carried out by various media organizations under the consortium of Center for Education, which was led by Platform for Investigative Journalism. Zodiac, Nation, Times Group, and Malawi Institute of Journalism and other media organizations were part of that investigation and that consortium. So we are today interfacing with you, led by the SH and other senior members from the Ministry of Health, just to appreciate how the corrupt practices are, hindering the service delivery in Malawi. But specifically, what we are looking for is the state of corrupt practices in health facilities. We know there are several issues that we can discuss, drug safety and others. But today, our focus is on state of corrupt practices or state of corruption in health facilities. So we are hoping that we dwell much on the pressure points, much as we appreciate that several issues that are compromising the service delivery, but let's focus much on their pressure points vis-a-vis the corrupt practices in the health facilities. May I therefore invite the SH to perhaps lead the discussion. Thank you very much.
Thank you very much, Honorable Chairperson. And thank you for the guidance on the approach. Each facility here had prepared their own presentation. It may take a little longer. So maybe I may appeal to the presenters to focus on the issue at hand. So if we can look at our slides, and where we can skip, we can skip. Those slides may be available for questions, but I think we may need to really focus on the issues that have been highlighted by the chair. There are 6 institutions or facilities. If we get each one to present,
I think
10 minutes?
Yes, I think that would be very helpful. So there are 6 institutions, facilities. If we can give them 5 minutes, 5 minutes each, will it be enough? Or 10 minutes? 5, 10? Okay, 8, 10 minutes. I think that would be enough. Yeah.
No, thank you very much, Chair, for the guidance. We'll start with the central hospitals, then we go to the districts. We'll start south, maybe Queens, and then come on central.
Thank you very much, SH. Thank you, SH, and thank you, Chair. I should also recognize my Member of Parliament, Honorable Kajumba. Thank you for this opportunity that we can present how we are faring on the issues of corruption in our hospitals, and thank you for the guidance. We may be wondering here and there because we were not sure how best to tackle this, but it was reasonably obvious that the events that happened in February are what led to this engagement. So we tried to dwell in that. I've got 28 slides. I'll try to squeeze them in 10 minutes. I'll give a quick introduction, then we'll discuss the Queen Elizabeth Central Hospital Integrity Committee, its mandate and operations, and special group sensitizations that are happening, and notable successes and challenges we have been meeting in our anti-corruption drive. As I said, this picture is recognizable to most of us. This was the investigation by journalists that was released on 14th February. And the question is corruption indeed taking place? That document did mention Queen Elizabeth Central Hospital as a place where the investigators came and they took note of 2 cases which were reported. So is corruption taking place at Queen's? The answer is yes, it is happening. I think on this slide that I've shown you is a letter of dismissal for one of our members of staff who was involved in a corrupt act, and the processes went through, and eventually he was dismissed from his services. So yes, it is happening. This is something probably that has been happening for a long time. It is not very new, so it is good that we can have this engagement to try to look for solutions together. I wanted us to look at the cases that were mentioned. There were 2 cases, and sometimes you don't know where the details are good enough, how credible could that be. So we had one case of a lady who came from Lunzu to Queen's for a tooth extraction, and she met her fate there. And normally what we're saying, do you have to go to a central hospital for a tooth extraction? This can be done at health centers and other places. You don't have to come to Queen's for a tooth extraction. So there's also note that she was asked to pay like 10,000 kwacha so that they can get the tooth extracted. But in our system at Queen's, because we are, this is not a service we should be offering. It's not a tertiary care service. We charge 10,000 kwacha. So everyone who comes to the dental unit, they pay 10,000 kwacha because it's not a service that should be offered by a central hospital. So we asked them to do that. So we don't know whether there was communication breakdown. There was another case that was mentioned, which a lady came from Palombe who had had surgery at Zomba Central Hospital. It mentioned that, and apparently had a mysterious painful swelling. Coming from Palombe, mysterious painful swelling, I don't know what they thought it was. Looking at the record, when she came to us, she went to the plastics department, so we think it was a keloid. A keloid is a swelling, that one. Some people, their skin is quite sensitive. If they have an operation, the skin does not heal well. So we think this was the problem. It goes on to say that the patient had a scan. Normally we don't scan these things. So when we are dealing with the media, sometimes we need to be careful. The information they give us sometimes may not be very correct. So that's the challenge that we had. But also we should note that this mysterious painful swelling had been taken to John Chirembe Hospital, but they had also gone to expensive private hospitals, to expensive private clinics. That is what it said. And that shows us the patients who come to us, what profile are they. So there are people who have managed to go to expensive private clinics, and can we leverage on that so that we can also offer them a better service? I think I'll come to that later. So when that notice came, what was our response at Queen Elizabeth Central Hospital? We held a staff meeting, a general meeting for everyone. It was covered in the media. This is a screenshot from Zodiac, where we outlined how we had planned to address this problem, Chair. So in this meeting, we did acknowledge that the problem does exist, as I've done so. But some of the challenges that we had faced was, Queen's is a very big place. We have got like 1,600 members of staff. And there are some people who come in and pose as if they are doctors or nurses. They infiltrate the system and solicit money from unsuspecting patients. And during this interaction, we did acknowledge that, and we'll discuss how best we can address that. Of note is that staff members did acknowledge that this is a problem, and there was willingness to address it. So one of the measures that we have is, there's a government mandate that institutions should have integrity committees. So we do have one at Queen's, which became functional in January 2024. It has got 4 aims, which is to lead in fostering integrity issues, to build institutional capacity, to deal with corruption, to promote institutional participation in the prevention of corruption, and mainstreaming anti-corruption activities. We have 11 members in the committee. The chair is here. And it's my discipline. I've got doctors, nurses, hospital attendants. They work together to address this. So their mandate, as we said, is there's a development function where they have developed an action plan on how they are going to do their work. So in this, there are several plans that they have made. I think for the sake of time, I will not go through that. We'll cover some of the activities. One of them is the development of the hospital fraud and corruption prevention policy. I did share this document. It's still in draft form, but we did send it to the committee. That is in progress. We'll be finalizing that soon. We'll be finalizing and launching that soon. We've also got a corruption reporting mechanism whereby we have posters around the hospital with phone numbers where people can contact should they be enticed to corrupt someone so that they get services. There's training that is happening for members of staff. This is one of the examples. So several departments have been trained. We're also having some specialized approach here. We have got a lot of security officers who, according to the report, were also involved in recruiting people for the corruption. So we have had a drive where we have addressed the security personnel so that they work with us other than working against us. We have also had same engagement with pharmacy and hospital attendants who have also been contributing quite significantly to the problem. This is some of the activities that we have been having. This is our famous Queen's dancing troupe, where they spread messages of health education, and they're also engaged in corruption drive, where they're spreading this message, going in the wards, speaking to guardians. One of the activities with patient attendance that was heard. We've had some cases which were reported. There was a time where Blantyre DHO complained that in one of our units, they were selling wheelchairs which are not supposed to be sold. That matter was presented to the Anti-Corruption Bureau. There was also another case where people who are not authorized to write medical reports, they were authoring medical reports, and that issue was also forwarded to the Anti-Corruption Bureau. The team has been working with the Anti-Corruption Bureau, where they're being trained on how to carry out investigations and how to handle suspected corruption cases. The committee also does provide quarterly reports, which are handled to my office, but also to the Anti-Corruption Bureau desk officer. So notable successes we have had, there is, I think, buy-in from hospital management. Hospital management is supporting the IIC activities a lot, such that the chairperson of the committee has now been co-opted as a senior member of the hospital administration. So each week we have a management committee, and the chair of the IIC is in that committee, where she addresses and gives updates on what the committee is doing on corruption issues. Challenges that the committee is facing. So there have been some delays in implementing some of the activities because of delays in funding from the ministry, because this is funded through our operating account. we're also having issues with health workers where they are shielding their colleagues. They're afraid that if they report them and then maybe they get dismissed, they'll be responsible for that. But with the sensitization that we are having, we think we will gain some ground. There's lack of motivation from staff because of low salaries, makes even reporting a problem because they think they have nothing to gain if they do that. But with the drives that we are doing, that is also making a bit of a difference. So drivers of corruption, which we have noted, one is the issue of staff shortage. Patients, when they come, they want to get a fast service. And where you do not have enough staff, you find that patients would look for other ways so that they can get their service and go home in good time. At Queen Elizabeth Central Hospital, we've got a vacancy rate for doctors of 60%. So you find that the 40% who are there, they are not, they can't offer a good service. We've got a lot of delays, and this does drive our patients to look for alternative ways so that they can get assistance quickly. There's also a problem of lack of standardization in our uniforms. I mean, we've said that people do come in and we don't know who is a member of staff and who is not, so we're trying to bring in uniforms so that people would know who is who. And then there's also porous access into our hospital. Queens is quite a big place and everyone is coming in, so it's difficult to know who is a member of staff, who is a street child and things like that, and we're trying to manage all that. This is a picture of one of the ladies who was caught a few weeks ago putting on a white uniform. She was collecting money from patients. And if this one is caught, they will say that staff are collecting money from patients. But from investigation, we found that actually she was not a nurse. If you can see the shoe, our nurses don't put on this type of shoe. It's not part of the uniform, you see. So we are trying to get controlled access into the hospital, whereby our staff are going to swipe cards so that they can enter the hospital. We think that will limit some of the people, and then we'll have IDs. We are working on uniforms now that the budget is operating now. We are working on getting uniforms for all members of staff. I think doctors, nurses, so everyone should have a uniform that can identify them. Then we have also installed CCTV cameras in some areas, and we will put up more as the funding allows. Thanks a lot, Chair.
Thank you very much. Queen's Central Hospital, very elaborate and insightful presentation there. I must also add, listening from you is very encouraging about what you are doing and the honesty that you have demonstrated in managing the cases at the Queen's Central Hospital. Thank you very much. We go to Kamu Central Hospital.
The cable can't get there. Huh?
Honorable Chair, members of the committee, honorables, SH and colleagues from central hospitals and district hospitals. We followed what you sent us to do, and we did according to what we were instructed, but of course, with the discussions, we might sharpen our discussion based on the direction that you lead us. So I'll present on the status of corruption at Kamuzu Central Hospital. I'll give you a background, and I'll provide evidence of cases from Ombudsman and Institutional Integrity Committee. There are 5 cases. Then I'll give you an outline of activities that Kamuzu Central Hospital has put in place to deal with some variants of corruption, recommendations, and also our conclusion on this matter as Kamuzu Central Hospital senior management. So as we all know, corruption in Malawi's public healthcare sector, it primarily involves the diversion of drugs. This is what we've been talking a lot more, and media has published more, to private pharmacies, better bribes, and illegal charges for a supposedly a free service. And investigations have revealed invisible tariffs at major public hospitals, including Kamuzu Central Hospital, leading to widespread government crackdown and also legal battles, which, if you recall recently, one of the perpetrators from another country nearby has just been released and given a fine of 850,000 after being found with quite a large volume of drugs. So what are we talking about when we talk about corruption? There are a number of variants and aspects. For example, we have extortion for free care diversion of medical supplies. We also have requesting for forex using false medical referral documents, misappropriation of funds, and also procurement corruption, which usually can be detected through audits. So, what is the evidence of corruption at Kamuzu Central Hospital? Case 1, I'll present to you Mr. GN, who was found in a department of surgery, endoscopy, reported on 30 September 2025. And Mr. GN raised a complaint on the nursing alumni WhatsApp group regarding his relative, the late Mr. K, and the allegation was that payment was required to access services at KCH during Mr. K's admission. Investigation was done by the Ombudsman, and following the complaint, staff from the endoscopy department approached Ombudsman's office seeking clarification and accountability. And their primary concern was to identify the individual who allegedly received the payment, as the claim had serious implications for the integrity of the service. And the amount of money was 90,000. Mr. GN was interviewed and reaffirmed that the payment was indeed made. But despite efforts, Guardian and Mr. GN declined to disclose the identity of a person who received the money. As I present the cases, I'll also highlight the bottlenecks. Mr. GN did not disclose who gave the money. Indeed, the findings revealed 90,000 was confirmed by both Guardian and Mr. GN. Identity of recipient could not be established as both parties refused to disclose the information. And the department was informed of the findings and they acknowledged of the situation. How was this case concluded? Given the refusal to disclose the individual involved, the matter could not be pursued further. The endoscopy department accepted the outcome and the case was formally closed. Challenge number 1. Case number 2, Mr. MC, Department Dental, reported on 27 April 2026. Mr. MC presented a complaint to the hospital ombudsman on 27 April 2026. He reported that he had been referred from Baila Hospital to KSH for tooth extraction, and upon arrival, he was allegedly asked to pay 18,500 in order to be assisted. Investigation was done. Mr. MC stated that he accepted the request of the payment and informed the practitioner that he would step outside to cash out the money from his phone. Instead, he came directly to Ombudsman's office to lodge a complaint. I want you to notice something in this case. When we sat down, we also thought this is a case of suspicion where people are taking advantage of a system where they get their things done earlier by also rubber stamping the fact that someone is involved in corruption. The head of department was immediately engaged regarding the matter, and the head of department identified a staff member to perform the tooth extraction. Mr. MC was assisted without making any payment. In terms of findings, the complainant confirmed that there was a demand of 8,500, and he was assisted for free, and he was put number one on the queue. The complainant failed to identify the allegedly staff member who demanded the payment, stating that he could not recognize the face as the individual was wearing a face mask. In conclusion, the complaint was addressed promptly and the patient received the required service without payment. However, due to the inability of complainant to identify the alleged staff member, the matter could not be pursued further. The case was therefore closed. Case number 3, FM and the doctors. Date 17 September 2024. On 17 September 2024, Ms. FM was involved in a road accident in Kamenya. She was referred to Kamuzu Central Hospital for specialized management. X-ray results revealed that had fractures. It was reported that Dr. NY and Dr. NK demanded 4 million from the patient's family before providing medical assistance. In terms of investigation, the patient's husband reported the incident to the police. The Malawi Police Service issued a police abstract report to Kamuzu Central Hospital. At the Institutional Integrity Committee, ICC, at that particular time, the ICC committee was not yet established. So the case was handled through the police intervention, and the Hospital Director General assumed responsibility for disciplinary follow-up. The findings, medical staff were implicated in extortion and denial of emergency care. Patient safety was compromised due to unlawful demands, lack of internal accountability structures at the time, limited hospital response. Action taken, case reported to police, police abstract report issued, Hospital Director General tasked with disciplinary measures. Case number 4, GN and patient at Lion, this is the Orthopedic and Neurosurgery Institute. It's a radiology case. This one you all remember, reported by Mr. GN. Mr. GN exploited his position by soliciting money from the patient requiring CT scan service for personal gain. Investigation, Mr. GN was caught red-handed soliciting money, and there was evidence of transfer of money through Airtel. He was reported to the hospital management. Disciplinary measures were initiated. In terms of findings, abuse of authority for personal benefit was confirmed. Soliciting money undermines patient trust and violates professional ethics. Hospital management responded promptly with suspension. Action that was taken on Mr. GN, this was the case that was all over social media, and the minister, this is the time the minister had visited Lion. Mr. GN was suspended pending further investigation. The last case, number 5. Staff at pharmacy. 2 pharmacists and a hospital attendant were discovered colluding to siphon drugs from the main pharmacy for private gain. This constitutes embezzlement and misappropriation of hospital resources. Investigation was done, case was reported to police and taken to court. The attendant was acquitted. The 2 pharmacists still in their internship program were disciplined. Findings, staff diverted hospital drugs for personal benefit. Incident represents embezzlement and corruption. Disciplinary action was taken against the pharmacists, though 1 suspect was acquitted. Action that was taken, case reported to police and prosecuted in court. Attendant acquitted, pharmacist suspended from practice during internship. As you're noticing here, the suspension was done by a regulatory body. This case was, despite going through the courts, these people were not reprimanded as thieves, as this was not taken as a criminal issue. Rather, it was handled as a disciplinary matter. Some of the bottlenecks. So, looking at all this and all these gaps that we have experienced in our health system, there have been some initiatives that the ministry has put in place. And of course, there is a policy that we should allocate resources to the Integrity Committee. There is a policy that each and every facility should have an Integrity Committee. So KCH has strengthened the existing Ombudsman Office and instituted a functional Institutional Integrity Committee. And this committee has undergone investigative training conducted by SCB, and KCH allocates 1% of ORT for all activities of Integrity Committee. Provision of toll lines for ombudsman reporting are available. And of course, complaint boxes in corridors and wards are also available so that people are able, those who can't go directly to the ombudsman, are able to put in their complaints or whatever issues they have had with the hospital in terms of management. The hospital has also designated an office for medical reports and medical board in case of any company compensation, because it's also another area where corruption is done. Standing order with commercial banks to report all forex requests using medical referral documents. We are called by banks when there is any suspiciousness of any medical reports for people to get forex illegally from the banks using a medical referral note. Information on corruption is also disseminated during our health talks by health surveillance assistants within our facilities. We have also introduced prescription pads with serial numbers to all authorized prescribers. One of the issues that we have discovered, how people are stealing medicines, maybe other facilities might also go and investigate on the same, is that most of the facilities use the yellow book. I'm sure honorable members, you know what the yellow book is. This is a health passport book. And most of the facilities use that book as also a prescription for medicines. Now, we have, at KSH, we observed that one person could come in with 7 types of medicines. Some are sick, some are not. But we have caught a few people and we sent them to police, and we discovered that these people were coming in quite large numbers per day, and they were collecting medicines using the yellow book. So they'll get 5, 7 medicines and send them to someone else, or would sell them to someone else who is buying the medicine from them. So one issue that gap has been filled. We got prescription pads from MOH, and that's what we are using. They have got serial numbers, and we have noticed tremendous improvement in terms of our stocks and also such malpractice. Procurement team has been oriented by ACB on corruption. KCH has gone cashless in option paying services with NBS, Airtel, and TNM. FGH is coming in to put in a competition. And of course, there is a banner, if you go to KCH now, on the left side on the same. These are some of the materials that you can see right here. We have the suggestion box. So we've also opened this and get the information in case some people did not want to meet the ombudsman himself. That's the prescription pad with our serial numbers that we have introduced at KCH, and we have noticed that there's been improved stocks in our medicines. That's our banner. That is now, if you walk to KCH as you're going up, it's on the left side where there is a skin clinic on the left side, and it reads, "You have now entered a corruption-free zone. Corrupt practices of any kind, shape, or form will be reported indiscriminately to ACB. Mujijewa zipupu za mtundu ina uluonse ndizoletsedwa pamalo ano aliyense opezeka kupanga nchitidwewu adzaperekedwa m'manja mwa ACB mosaona nkhope." What other initiatives are in the pipeline at KCH? Installation of CCTV is at final stage in terms of procurement. I know our colleagues have already implemented it. KCH will install audio-visual information platforms. We are putting TVs and with recorded information so that when patients are sitting, they're able to internalize information on corruption and other messages. All members of staff will have identification cards and name tags, which is also at an advanced level to make sure that we don't just allow everybody else to walk in. In terms of our recommendation, we still recommend strengthening the existing systems at health facilities. Ombudsman integrity committees. These should be strengthened, and we need to sit down and also see how best they can help the facility. Parliamentary Committee should engage media houses to help MOH advocate for existing services for reporting corruption. I know it is the responsibility of media to report such issues, to sensitize the masses, and also make sure that the perpetrators have been taken to book. But we would also want the Parliamentary Health Committee to engage the media houses in Malawi to make sure that they are not only good at reporting corruption in Malawi, but they are also able to report the measures that the MOH has put in place to deal with corruption at health facilities. And also we would like to ask the Parliamentary Committee to advocate for stiffer penalties. For example, the issue of a person who has just come out of the custody after paying 850,000. These are people who are supposed to spend time in prison. Other countries, stealing medicines in hospitals is considered as a treason. But here they're having a fine of 850,000, and that's too little in my case for someone who is literally killing people in these facilities. We should also advocate, as honorable members, for improved condition of service for all healthcare workers in Malawi. the people need better remuneration, they need better packages, so that some of these, we could deal with 20% or 50% of some of these issues by also increasing remuneration of these people. In conclusion, the current reporting systems are working according to our observation. There are people are able to report to Ombudsman, people are able to report to anti-corruption, people are able to be taken to book despite that there are some other bottlenecks, which as a system or as stakeholders, we can sit down and see how best can we make sure that some of these cases are properly concluded. But in our opinion, the systems are working, people are able to report. We should advocate for such systems to be used by the masses. People should report to Ombudsman, to anti-corruption, and not to social media. Cases that have been reported to social media, some of them, we have not yielded anything. But cases where they have been reported to corruption and Ombudsman, we have done better in terms of outcome. We need to support and strengthen existing systems, and perpetrators must receive stiffer penalties. Those are our references. So we use the Ombudsman data, we use the Institutional Integrity Committee data, and also investigative journalism. Thank you so much.
Thank you very much, Doc. Very passionate reporting there. The presentation, the eloquence, the authority. Well, excellently delivered. Mr. GN, Mr. FM, I hope all our members you are taking note. That corruption seems to be two-way. Could be coming from the patients, but also from the other side. Thank you very much, KCH, for that beautiful presentation, and of course, some revelations that are coming from that side. In Zuzu Central Hospital, it's your time.
Once again, good morning, Honorable Chairman, and also good morning, all Parliamentary Committee members. So my presentation from Zuzu Central Hospital, my colleagues have spoken a lot, so I'll try my best not to overlap, but just to make it a little bit clear to the members and to the team, Zuzu Central Hospital has got a different situation compared to Kamuzu Central Hospital and Queen Elizabeth Central Hospital, in that in the northern region, we are not as congested as our colleagues, therefore our challenges can be quite different. At the same time, from Zuzu Central Hospital, we do not have many larger health centers that act as gatekeepers. And therefore, as a central hospital, we cater for primary, secondary, and tertiary level. So we do not block patients from coming in, rather, they pay a bypass fee if you do not want to go to the smaller facilities. So in terms of Zuzu Central Hospital, our management oversight and governance arm, we provide tertiary care services and we serve 6 district hospitals in the northern region. And in terms of our services overlook, we have established committees that reinforce ethics and integrity at our institution. So we have an appointments and disciplinary committee, which is reactive or punitive, and we manage cases that are below grade K, and above grade K, we refer it to central government. We also have Institutional Integrity Committee, which is proactive and preventive, and we have the Ombudsman Office. These members of the committee are nominated by the senior management members, and we have a 2-year serving time for all these members. In addition, those that are in the Appointments and Disciplinary Committee, as well as the Institutional Integrity Committee, are sworn in. And these committees work with the hospital management, Anti-Corruption Bureau, the police, state advocates, central government, and Government Health Services Commission. So the forms of corruption that we've identified and dealt with at Zuzu Central Hospital: fraud. During the COVID time in 2021, we had a case of COVID-19 funds fuel mismanagement, which was picked up by an audit and it was investigated. It was involving an accountant who was mismanaging our fuel. And this individual, being above grade K, was interdicted by Ministry of Health, and the matter was investigated and was submitted to court. So as we stand now, this matter is still being sorted out by Ministry of Health. And on the illegal collection of bypass fees, so like I said, in Zuzu Central Hospital, we're much bigger on bypass fees collection rather than on charging for services when a patient does not want to attend a primary health care facility. So we had a case where a nurse was found to have been collecting bypass fee from a patient with no government receipt issued. That was over the night. And when this was investigated, it was indeed found that the nurse gave her personal phone number. And like Dr. Amos Sengendana had said, this matter was pursued further. Unfortunately, it was only the Nurses' Council who ended up suspending the nurse for collection of the bypass fee and also other mismanagement issues. The matter did not go any further than that. And then on the second case, we had a clerk who was issuing fake government receipts and pocketing the money. We had 9 complainants that came up, and we suspect that there are more. So being a grade K and below, our appointments and disciplinary committee attended to the case, and then this individual was warned by Human Resource and was told to reimburse and continue to work in our facility. We have alleged charging for service delivery. I'll say alleged in areas of theater space. Some private clinics allegedly using public services and charging their patients. We have alleged complaints from mortuary, ultrasound, and surgery. I say this because we hear rumors, but whistleblowers do not come forth to say, I gave this amount of money for this service. So we've chased several rumors, but all the whistleblowers refuse to submit their names. They refuse to come to an interface meeting, despite trying to assure them that they remain anonymous, and all of them do not want to go to the Ombudsman. So from Zuzu Central Hospital, for now, we're not saying no, we are not faced with this, but unfortunately at the moment, we do not have an active case that we can say we've pursued and we've completed. When it comes to theft or collection of hospital resources without authorization, we had a case, theft by pharmacy personnel. It was reported to Minister of Health because of the grade. He was interdicted, and I went to the police. He went out on bail, he absconded, and he was removed from our payroll. Unfortunately, after that, he went missing. He attended the walk-in interviews. Unfortunately for him, he was posted again to Mzuzu Central Hospital. He did not report because HR noticed the name that this person has a case. It's not closed. He absconded, removed from the payroll, but through the walk-in interviews was picked again. So he was not employed. So at the moment, we're not sure where he is. We have another one. It's a current case, same. It's theft, but I feel it's a combination of theft and corruption of a pharmacy technician and 2 clerks who at the moment are suspected for stealing drugs and supplies. As you all know, Mzuzu Central Hospital has recently installed CCTV. So we have evidence from CCTV, the clerk's office, and also witnesses, some of them who were part of the chain but were not being persecuted. So all 3 individuals were interdicted, and then they were the police. At the moment, I understand they're out on bail. On Mzuzu Central Hospital side, the state advocate is involved. Of note, 2 of these individuals are repeat offenders. The one individual who's a repeat offender is a repeat offender from a previous facility, local government, 2 facilities, but because of the gap in paper trail, he again came to Mzuzu Central Hospital and came in as first appointment, although in the previous 2 facilities, he actually resigned. So that's actually a big gap that we've identified in human resource management. And the one clerk is a repeat offender. He's the one that had the illegal government receipts. So when I say illegal government receipts and getting money from patients, he was issuing receipts that had the same receipt number. So we know that these were not our receipts. So 2 of those people are repeat offenders. So interventions done by our institution, we do regular sensitization of members on corruption prevention. We investigate the alleged corruption cases. We monitor our procurement processes from bid submission to evaluation using our internal integrity committee. We do audit and risk assessment for the departments. This is through the integrity committee, especially in OPD, which is outpatient department, and also drug management. We have established reporting mechanisms. We've installed complaint boxes. We have an integrity email, and are in the process of procuring a phone to receive complaints. And also we have established and maintained the Office of the Ombudsman. Under policy development, we have a draft policy on fraud and corruption prevention. And also we have intra and interdepartmental coordination between the police, anti-corruption bureau who comes in to train our staff and give guidance to our integrity committee, and also with central government. Like I said, we've recently installed CCTV in the high-risk areas, and looking at the result, because the recent case that we've had, we're able to go back and see what is actually happening with the case. But because it's a police case, I'll be unable to share more details on that one. So what are our challenges? Human resource management. We noted that the recruitment system for the Malawi government or for the health system is not well coordinated. This is intra-departmental and inter-local government, meaning between the central hospitals and local government, there's no linkage between the systems. Someone can be employed at a local government and be dismissed, and then they can walk in, have an interview at a central hospital and be taken up. So it means the file remains at the local government or at that district hospital. It's not forwarded to the central hospital if that individual does not admit that he was currently employed elsewhere. In addition, members who seem to have resigned from local government are being given a fresh opportunity to be first-time employees at a central hospital, which we thought was a big loophole, because if someone has done something at a council or a district hospital, they end up having a new opportunity in a central hospital or the next council, because it's all paper-based, it is not digital. Secondly, we've noted that there's a delay in response to cases above grade K by DHRMD, meaning that either the interferences or just delayed responses to a point where someone is then ending up being reinstated, or they're just deleted from the payroll, or they move off and they're transferred somewhere else where the matter and the case is not closed, and then they start again in the next facility, and in another 2 years, that facility realizes that actually this person is a troublemaker. They follow up from the previous facility and they see that their case was not actually closed. Under legal, in the northern region, we don't have an attorney general's office. So when we want to seek legal counsel, we're given different officers from Lilongwe, and also different lawyers do move up and down between Mzuzu and Lilongwe, which is disruptive because we don't have any institutional memory with the lawyers. And there's no desk officer from Mzuzu Central Hospital, meaning that whoever we call, we get random people who are assigned to us. And in our establishment, there's no lawyer, and currently at Minister of Health, there is no lawyer. Whistleblower fear is a big one. There's a lot of bullying and intimidation. In our current situation, we actually have the individual who was not even a whistleblower. He just noticed that there was something irradical happening. He's being extremely bullied by his peers within the facility and by his peers within his career line. So that is actually quite sad. He's scared and he was actually crying. And I feel like other members who saw what's happening to him would not want to whistleblow. There's a security risk, a personal security risk and fear of retaliation when they report. And also there's just lack of clear trusted whistleblowers and witness protection mechanism within the hospital systems and the police. So when someone whistleblows, they're left to their own devices. So I think a lot of people are scared, especially if they're going to whistleblow about senior officers. We have interference of cases at different levels. This could be either a ward in charge dismissing the case, this could be a hospital manager dismissing the case, this could be a relative of the one who is allegedly being caught in the corruption practices from higher levels trying to interfere with management of the case. So some of the cases, sometimes they end up in limbo just because there's interference at different levels. In terms of the committee challenges, most of our committee members, they delay in investigating because they are multitasking, and there's still inadequate training and skills of our committee members on investigation of cases because of their high transfer out rates. We have also noticed that there's lack of coordination between regulatory bodies, government agencies, and courts. Like Dr. Segandana has said, some of the consequences faced by the health workers are coming from the regulatory bodies. So sometimes we can prosecute an individual, but the regulatory body is unaware that that case is in court, and vice versa. When a case is in court, the regulatory bodies are not told. And then also we see that there's lack of coordination between the police and facilities. Most of the times when we send our cases to the police, that's the last we hear from them. Sometimes they say you don't follow up, and then they say, no, we need your security to follow up with us, and most of our security are on contract. But there's just not that good feedback mechanism. So a person is sent to the police on a case, and next thing you know, the individual is out on bail. The next thing you know, the case has been dismissed, and then the person is coming back to work, or sometimes it's transferred out. So the coordination between the two and the share of information is lacking. And then some cases, they can go to the police and the state advocate is not aware. So that's also another gap. Under cultural and workplace norms, there's a lot of discouragement of reporting and protection of the perpetrators. It seems like corruption is rationalized by members of staff. They take it as a normal thing. And there's inadequate reporting of the cases by both staff, patients and members, and patients and guardians. So what are our recommendations? We need to strengthen our security systems. Should we have a policy of installing CCTV in all government institutions, the corrupt-prone areas? It's time that we recruit qualified government security personnel, meaning that we need to recruit personnel that have a qualification, not only an interest in security. As we're moving on towards recruiting security that are on contract, our own security personnel has shrunk. So for example, we have CCTV, but we do not have the manpower from government side, from our institution, to be manning the monitoring of that CCTV, because you cannot always trust those that are on contract. We need to digitalize and integrate human resource systems, central government and local government, during the recruitment of qualified personnel. We need to go digital so that when we enter information about an individual, on his identity, it should come up what has happened on the local government side. It should also come out what has happened in the other central hospitals. And there also needs to be some form of integration between police, court, and central government. You enter someone's identification number, immediately you see that this person had a court case, immediately you see that this person was in jail. Because even though when people are being recruited, most of the times they just ask, do you have a court case or not? And if they say no, we go by word of mouth. But it seems like now we're beyond trusting word of mouth. We also need to digitalize hospital operations and systems. Cash collection and inventory management is still paperwork, so we can easily manipulate the paperwork, especially when it comes to drug theft. If it's digitalized, it's difficult to manipulate the system. Our MPSR, we understand it's under draft, needs to be updated, but also we've noticed that we have stopped induction of personnel into civil service. They come into civil service, are not well oriented. And secondly, it needs to be a mandate that managers need to be oriented with the school of government, because majority of our managers do not know what MPSR is and also what is the expectation from civil service. In addition, strengthening governance systems. Under witness protection, we need to have a formal establishment of whistleblower protection for health service employees and witnesses. This must be legislative and regulatory backing. We had one individual, I think a doctor, who was really very scared for a long time that we had to have some sort of security coverage for him, but you can just imagine if we had not listened to him, what could have happened to him. Ministry and Parliament to provide independent witness protection and assurance for patients, a guaranteed continuity of care, for example, and also fund anonymous reporting, such as a secure digital submission. We need to provide legal and psychological support for complainants and protected staff, and fast-track protective measures where risk is shown. From Zuzu Central Hospital, that is all. Thank you.
Thank you very much. Thank you very much for that wonderful presentation. Zomba Central Hospital?
No, Zomba was not invited.
Oh, okay. Thank you very much. We go to...
there's Cholo, there's Chirazuru, there's Likoma.
We start with Likoma, please. As I said, let's focus much on the pressure points, the most critical part that you need to share, please.
assistant here.
Honorable Chairperson and the members of the Honorable Committee, HS and colleagues, good morning. I am Abubakar Nkoma, District Commissioner for Likoma District Council. I would like to report on the state of corruption in Likoma. Likoma district does not have a district hospital. We rely on St. Peter's, an Anglican charm facility for the health services, but we only have lower level kind of facilities. So Likoma is located in the Lake Malawi, closer to Mozambique, about 70 kilometers from Nkata Bay and 10 kilometers from Mozambique. And in Likoma, we have two islands of Chizumulu and Likoma. And about 45% of our patients come from Mozambique. So this information has a bearing on the presentation which I'll make in terms of state of corruption. I will skip the mandate and the goal of the directorate and strategic objectives. Honorable Chairperson, due to the fact that we don't have a government facility, but we still provide the services because we have the Director of Health and the Chief Nursing Officer and other government officers who work at the CHAM facility. So under the current management, the government through the District Council provides the drug, medical supplies, human resource, medical equipment, payment of locums and utilities. So the referral services are also provided by the District Council. So in terms of referral, our main referral systems, we send our patients to Zuzu Central. Sometimes we also send them to Nkota because of the means of transport. Because we use land, air, and water for referral services. So in the case of corruption, Honorable Chairperson, I have two scenarios which was reported in social media. It is a case related to a patient which happened in March 2025. A patient was bitten by a crocodile in Mozambique, and he was brought to Likoma and sent to St. Peter's Hospital. And when we felt that we couldn't manage it, we referred the patient to Zuzu Central, So from Likoma, then we had to use our boat ambulance that was donated to us by UNICEF. And from there, we picked the patient from Nkatabe to Nzuzu Central. So from the media report, the patient is alleged that he was demanded to pay 75,000 kwacha on a speedboat to be evacuated to Nkatabe to contribute to fuel. But our speedboat uses 300 liters of petrol. And that was the only passenger, with guardians, of course, referred to Nkatabe, to the Central Hospital. So it is also further alleged that while at Nkatabe Jet, the guardian was requested to pay 55,000 kwacha to a driver to top up fuel because the ambulance didn't have adequate fuel to transfer the patient to Nzuzu Central. So following the allegations, management instituted investigation to establish the facts of the matter, and we have attachments of the details of what happened. So during the hearing, we started with the boat crew, who it is alleged that they demanded 75,000 kwacha. So in March 2025, we invited the boat crew and transport officer to inquire about what happened. But both the transport officer and the boat crew indicated that they didn't demand any money. Then, Honorable Chairperson, we made some efforts to meet the guardian, but we couldn't because on the case file, it was just indicated Mozambique in terms of address. So management failed to conclude the matter because the guardian could not be traced to give evidence of at least what happened. Then situation 2 was at Nkatabe Jet. The patient arrived around 9 p.m. From Likoma at Nkatabe, and before the arrival of the patient, the driver for the ambulance called the transport officer indicating that he didn't have enough fuel in the vehicle to refer the patient to Nzuzu Central. And because the transport officer could not be reached, then he referred the matter to the DHS, who told the driver to ask, because we couldn't have fuel, our card didn't have fuel, so the DHS instructed the driver to ask the guardians if they can contribute fuel to refer the patient. Then the driver asked the guardian rather, and they contributed 55,000 kwacha. Then the driver drove all the way to Nzuzu Central and escorted the patient to Nzuzu Central, who later on was treated. On his way back, the driver fueled the vehicle. So in terms of corruption, the issue came in because the driver drove off from Nkatabe to Nzuzu Central without stopping at any filling station. And the driver claims that on his way back, that's when he fueled the vehicle. So in the absence of the guardians. So when we got the matter through social media, then we also invited the driver for hearing. And the driver admitted having collected 55,000 kwacha, but he said the fuel that he had was enough to take him to Nzuzu, and then he felt he could just fuel the vehicle on his way back. So management, when he heard the report, after he had submitted the written report, warned the driver because he acted untransparently, because as much as he didn't have fuel, he was supposed to ask the guardians to fuel the vehicle and then proceed to Nzuzu Central. Currently, in terms of referral system for Likoma, it is rather expensive because from the hospital facility at St. Peter's, we take patients by the ambulance that we have, a motor vehicle ambulance, to the jet in
3 minutes to go. 3 minutes to go.
Thank you, Honorable Chair. And then we take the patients through using the speedboat to Nkata Bay, and there we also have another ambulance, motor vehicle ambulance, to Nzuzu Central. So our system is such complicated because of the way we are located. So as a district, we have the Institutional Integrity Committee that looks into issues of corruption, and we also engage the media houses that we have to encourage the community to report cases of corruption that may happen in our facility or within the district. So this is just how much is costing us in terms of referral. It's about 3 million kwacha for each trip that we make when we are referring patients from Likoma to Nkata Bay. So the challenges that we have are inadequate and delayed funding, the ORT, larger number of unbudgeted clients, especially from Mozambique, accessing services in Likoma, while funding is allocated based on the population for Likoma alone. Weak referral systems, which is also expensive, and inadequate health workers who shun the district due to a number of reasons, including accommodation, and inadequate number of partners to support the district, and also lack of isolation units for infectious diseases outbreaks. Honorable Chairperson and members of the committee, I now submit our report from Likoma District. Thank you so much.
Thank you very much, Likoma District. We quickly go to Chiradzulu District. Like I said, let's focus much on the pressure points, the state of corruption in the health facilities. How much is it contributing, or is it compromising the health service delivery? Are patients having access to the services that are supposed to be free, or are they being charged through corruptive practices? Chiradzulu District Hospital.
Firstly, Honorable Chair, I would like to express our gratitude as a council for this opportunity to come before you to present our side of the story. We came to know about the issue of corruption happening at the district hospital through a newspaper article. Chair, I would like to inform the committee that currently there is any registered case of corruption at the district, but this does not mean that there aren't cases which indicate corruption. The question is, does the absence of any registered case mean there's no corruption? The answer is obviously no. So, after getting those allegations, the first one was about informal payments for services. The district council acknowledges that public health systems operate under the pressure. Operating under pressure may become vulnerable to unethical conduct by individual officers if monitoring and accountability systems are not consistently strengthened. The assessment further recognizes that patients experiencing emergencies or distress may be vulnerable to exploitation. Informal practices can emerge where there are several bottlenecks or prolonged waiting times. Fear of retaliation may often discourage patients from formally reporting corruption. We had a concern regarding unauthorized intermediaries, agents. The district council noted that large patient volumes and overcrowding may create opportunities for exploitation by unauthorized individuals. Some non-clinical individuals may take advantage of vulnerable guardians and familiar with hospital procedures. So the risks would be patient navigation challenges, whereby they may not know from here, where do I go to get medicine? And some may take advantage of exploiting them or letting them pay something. Limited monitoring of waiting areas and inadequate public awareness regarding official procedures. Concerns regarding unauthorized intermediaries, interventions undertaken, we said we had to enforce security oversight. We had to institute pre-qualified list of prescribers. Those who prescribe the medicine who have to know them, so that when they go to the pharmacy, the one prescribing the medicine should know that this one is the one to prescribe the medicine, and also increase the supervision of all the departments. There was another allegation concerning the use of government resources for private gain. The officers referred in the report had previously retired from the civil service and had been seen lingering around the hospital premises. Upon becoming aware of these allegations, the district council initiated an immediate administrative review. The permanent ban was made for any retired officer to be within hospital premises unless he or she is ill. Supervision within the department was intensified, and theater oversight and access controls were strengthened. Departmental accountability measures were also reinforced. We have another allegation relating to use of government resources. Yes, we continue. And we enhanced the monitoring of temporary staff engagements to avoid having unknown people working in our district. We had another concern regarding mortuary services. The district council recognizes that bereaved families are highly vulnerable and require a compassionate, ethical, and transparent handling. Any informal charging outside government-approved procedures undermines public confidence and compromises the dignity of the affected families. So we reviewed our mortuary operational expenditures, reinforced ethical expectations among mortuary personnel, and displayed information regarding approved services. Another concern related to recruitment integrity. Our council maintains that recruitment processes within the public services are expected to follow government procedures, emphasizing transparency, merit, and fairness. Therefore, we have strengthened on that area to have transparent recruitment documentation and recruitment processes, as well as selection when we have the chance. So we have also used suggestion boxes more. We have put them among a lot of places so that we get anonymous complaints as much as we can, so that we can deal with them. The hospital ombudsman is working so hard to help in complaint resolution, and we have got complaint registers where we document, we will be documenting, and we have been documenting. Community engagement structures are being used as an oversight. We have a number of hospital management meetings to be as hospital oversight, and IIC committees as an oversight. So immediately when we had these complaints, there was an emergency meeting briefing by the district commissioner, the spot checks to find out, briefings, as I have mentioned, and reinforcement of government policy, and reminder on ethics and professional conduct. And we have also increased the number of awareness among other officers, to the extent that we have even made golf sheets written, we don't want corruption here. So they have first to be given as the managers, then will trickle down to the others, as one way of showing that we don't want any corruption. So within 3 months, we have done that. That which we have said, and we have also put on the way to the hospital our poster showing that we don't tolerate corruption, and we have put pictures to show that we have got an ombudsman. This is the way if you have complaints and the like. We have short and long-term plans to keep this. The ones concerning meetings, hotline, immediate measures. And we have some medium-term measures in place. We want to have quarterly integrity audits to find out what is happening. We want to have risk-based supervision so that we detect early anomalies, and community awareness campaigns, mid-term measures, and even civil society engagement to assist us. Long term, we want to strengthen ethical leadership culture amongst all workers in the district, and to institutionalize integrated trainings, not only for council managers, but for medium as well as even the low class officers. We want to improve infrastructure and patient flow to build a number of health facilities so that waiting time for people should not be too much. We want to expand to digital systems as the central hospitals are doing. We want to strengthen workforce recruitment. We should be transparent enough, and we want to have many specialist staff, because if we have a lot of them, some will not pretend to say, I'm a specialist, come to me for such assistance, and also to enhance independent oversight. In summary, Honorable Chairperson, the District Council acknowledges the seriousness of the allegations and recognizes the need for strong accountability and governance systems within healthcare services. Chirazo District Council has already implemented corrective interventions aimed at strengthening supervision, improving complaint handling systems, reinforcing ethical conduct, and protecting patients from exploitation. The Council reiterates its zero tolerance towards corruption and remains committed to ensuring that healthcare services remain free, equitable, transparent, and patient-centered. Finally, the District Council will continue working collaboratively with Parliament, the Ministry of Health, oversight institutions, and communities to strengthen public trust and improve healthcare governance and service delivery. Thank you so much.
Thank you, Chirazulo District Council. Just to put you up to speed, you have told this committee that you only learned about the corruption through the media. You have also considered that that doesn't mean corruption doesn't exist at the institution. Honorable members and the committee membership, take note as you are preparing for your questions. We go to Cholo. Yes. Please, let's focus on the pressure points, the most critical information that you need to share with the committee. Thank you.
Thank you, Chair and honorable members. In minutes to come, presentation by Cholo District Council, and will be done by myself, Noro Dagamau, District Commissioner. Cholo District Council is committed to provision of equitable, free and quality health care services. Extortion, bribery, corruption, and informal charging of patients are unacceptable. The district is committed to transparency, accountability.
Point of order, Chair.
Point of order. What is out of order?
The member should put the mic closer because we don't hear him here.
Point of order sustained. Please come closer to your mic and speak up, please.
Thank you, Chair. The district is committed to transparency, accountability, and cooperation with the oversight institutions. The District Council Chair and the District Health Management Team oversees health services delivery, governance, accountability, and quality assurance across facilities. The Council is prepared to present the Council's official position, provide available facts and documentations, and respond to the committee's questions accordingly. The Council's shared interest to protect public resources, maintain confidence in public institutions, and ensure uninterrupted delivery of quality health services to the people of Cholo. As a matter of knowledge, the Council has 2 big hospitals, 1 CHAM, 1 government. In total, the Council has about 47 different facilities. In terms of human resource, the Council establishment is 3,123, currently filled 1,378, representing a 42%. This is the summary of vacancy rate per category. Annuality, about 1.1 billion, out of which 124 million is for drug. Just an overview about the government policy, that the following services, Chair, are free: outpatient services, inpatient services, maternal and child health services, emergency care, essential medicines, dental and ENT services. However, medical reports, embalming services, office rentals is at a fee. But why are we here today? Why are we appearing to the Health Committee? On 15 February 2026 Chair, a platform for investigative journalism, reported in their report, Pay Up or Die, the Shadow Corruption Networks Running Malawi's Public Hospital, Cholo was mentioned in the story with a subheading, The Weapon of Neglect in Cholo. What are the allegations alleged in that paper? A patient reportedly not receiving proper medical care for approximately 3 weeks, despite having a broken leg. A rural villager from Fatima alleged receiving only 8 Panadol tablets for an injury. And the third one was an elderly man alleged being informed that his leg would require amputation, with no hope given regarding treatment or medical interventions. Is this the only reason why we are here, Chair? Certainly no. The reports from Ombudsman. Case 1. On 26 January 2026, the office received a complaint that patients are referred to a private hospital to get POP. An investigation was made, and the arrangement was done at the office that if POP is finished, patients shouldn't be referred, let alone let them go to private clinic themselves. Case number 2, uncertified with a service received. Our office received a phone call from BD stating that she was not satisfied with the treatment she received after experiencing a miscarriage. Later on, upon visiting the hospital staff, she was cared and confirmed that the revised services was satisfactory. Chair and committee members, on 10 March 2026, a girl named S.E. from CBX village, 24 years, went to Ombudsman to complain that there is no privacy at the ART clinic because that direction is only ART and the OPD. Chair will confirm that it's true. The only challenge is the ART room. There is a lot of investment. So maybe we need to find another room to transfer. Donors put a lot of investment in the room. Maternity case. On 8 May 2026, we received a complaint from JB. JB delivered twice on C-section. This time around, she was pregnant again at the third time. So upon arriving at the hospital, she thought she was to be told to go for C-section. Unfortunately, she was told to wait, and this waiting was to allow the baby to mature. So JB did not like this from the hospital officers. Lack of privacy at under 5 clinic. Chair, it was also reported that there's no privacy at the under 5 clinic, regardless of the case of the patient. We confirm that patients in law of 5 are invited in the room because of shortage of rooms, Chair. Complaints about patients being referred to a private clinic for FBC. Chair also noted that the same as the POP, the patients were referred to a private clinic, whether in good faith or not. That's why we are here to explain. Unfortunately, at the private clinic, people were paying 12,000 kwacha. So it's alleged that we are promoting the private clinic business. Out of all this, Chair, there's no formal documentation complaints which has been submitted, verified names, date, locations, all affected patients to our office. All the information which we are presenting here, Chair, is from the newsletter and the complaints registered at the Ombudsman office. No health worker, Chair, is authorized to demand personal payments in service delivery. What action did we do before and now? Having active hospital ombudsman, which receives complaints from patients, community members are independent from direct patient care, and also they provide governance, technical and financial support without interference. We have visible notice stating services are free, increased supervisor rounds at the hospital, of course, a refresher ethics training in the morning handovers, confidential inquiry mechanism, protection of whistleblowers. As to conclude the presentation, Chair, let me say the medium-term measures, quarterly integrity audits are done, strengthen record mechanism, enhancing community participation, hospital advisory committee management, and civil society collaboration. In all of these, Chair, the District Council has introduced the digital information display. Currently is on a pilot. It's a 70-inch TV screen, paid GoTV, is running with MBC as a pilot. Our intention is the Council will display video updates for the projects implemented in the district for the community to appreciate what is happening in their council. More than that, Chair, we will feature videos, word information from all sectors, including Hefe, Member of Parliament, councillors, traditional leaders, among others, for the people to know where to get what, when, and what type of services. In this way, Chair, we are sure that people will be satisfied with the services which they will receive. More than this, we'll give information as to where to report cases related to corruption. In conclusion, Chair, we would wish to increase staffing levels, do investment in digital systems, of course, improved infrastructure and the medical equipment to ease congestion at the hospital, and also improve on public awareness and patient rights programs. Tolo District Council Chair condemns corruption in the health sector. The Council remains committed to investigations, transparency, restoring public confidence. The Council further reaffirms its commitment to transparency, accountability, and continuous improvement in the delivery of health services to the people of Cholo. The Council appreciates this opportunity, Chair, to provide clarifications and engage constructively on the raised allegations. I submit. Thank you, Chair.
Thank you very much, Cholo District Council. Just like Chirazuro, Cholo District Council also learned of the corruption cases that the institution through the media. They haven't told this committee if they had an interface with the media just to learn more about the cases. They also haven't told this committee whether they took time to investigate the matter. What they have told this committee is that they have these cases which haven't been formally reported or lodged with the institution. Honorable members, take note. Before we go into plenary, SH, may you have something before we take questions? Do you have something to say?
No, thank you very much. I thought, Chair, I may beg from you that maybe people may have 5-10 minutes health break.
That is granted, and we have refreshments at the back. Let's partake. These are for all of us here. Thank you very much. I think we'll break for 10 to 15 minutes or 10 minutes.
10 minutes should be enough.
Yeah, 10
Chair.
minutes,
Yeah.
right.